Hi, this is Beverly Zaleski, and I'm going to be talking about schizophrenia tonight, as well as Abilify Maintena, which is the medication I chose, which is an atypical antipsychotic injectable. Schizophrenia is a serious mental illness, and it's going to present differently through our clients, depending on their level of symptoms and how they can express themselves, which are all affected by schizophrenia. So we're going to have to be very good at supporting our clients. So one of the things you're going to look at, I'm going to be using the DSM-5 for my source, and that is the positive and the negative symptoms, because both play an important role in the medication that we're going to be looking at. Positive symptoms would be the delusions. That's for the fixed beliefs that are not going to be changed. And there's different things for those. The most common would be the persecutory, where our client might think someone's after him. And then also there's the referential, where everyday experiences take on different meanings. They're directed at our client, and our client spends much time thinking about what those messages meant. Now, we have to remember that with the delusions and also with our thought disorder, in every area of diagnosing, we have to be very culturally sensitive and watch our language biases, because what we might be interpreting in terms of from a cultural perspective is not always accurate. So we have the delusions, we have the hallucinations, which are auditory and visual, but also anything with the senses. These are very real. It's hard to tell if they're reality or if they're not, and they're clear, vivid. And so the most common would be the auditory, and that would be where our client is talking about hearing voices, noises too, but also voices that are not their thoughts. And like I said, any of the senses, we have the visual, where they might be seeing shadows from the corner of their eye, or more vivid. Then there's also the thought disorder, or disorganized thinking, and that's expressed through speech. And of course, this is where our client might be jumping from topic to topic when we're meeting with them, and also talking about things unrelated to what we're talking about, so tangential. Again, language barrier has to be watched, just in case someone is not expressing a thought disorder according to their culture, because we're just not understanding them. So a thought disorder really basically is a positive symptom, but it interferes with communication. And then we have also the gross abnormal psychomotor behavior. This includes catatonia, gross and disorganized. Disorganized in the sense that the movements sometimes don't make any sense. There's no sense to them. They're not goal-oriented. They can't accomplish when they're doing these kind of activities. They're not able to. Our clients aren't able to complete activities of daily living. So you can see how that interferes. But one of the things we have to remember, a really important piece of that is catatonia. And this, especially in the early, when people are first experiencing schizophrenia, younger people, it's at 20, 23, 26 for most folks, not knowing what's going on. And so the catatonia can look like negativistic behavior, almost like disobedience to the parents. And then also, catatonia can lead to be totally shut down, not even being able to move. And also striking weird poses, we'll see the grimacing, and we'll see the behaviors that make someone look odd to other people. Now, also then, the negative symptoms are important, because this is going to be the cognitive piece that continues to affect our clients, even if the psychotic symptoms aren't active. They're not in an active psychotic episode. I mean, with the active symptoms, the positive symptoms. They're also can be confused with mood. And this is where the flat affect, or the lack of emotional responsiveness, flat, no eye movement, just no change in voices. But also avolition, which could be determined as, looked at as laziness, but basically is a lack of self-motivated behavior. And it also could mean lack of ability to experience pleasure, and not wanting to, or not able to interact with other people. And then also, maybe not talking too much. So we really want to look at that piece and make sure that we give our clients opportunities to understand what's going on with them, and then also have social interaction and build those skills. One of the things about schizophrenia, there's really no known etiology, and which makes it confusing for not only our clients but for us. But there's certain things we do know about it. It's definite changes in the brain have been noticed through neuroimaging. Certain parts of the brain are smaller, and also there's less volume of gray matter. There's problems in the white connectivity, and the cell structure, of course, of the major parts of the brain could be different. And so it's also genetic, and genetic, the reason it's so hard for researchers to target which genes, because there's several genes involved, and they each could have various nuances of, abnormalities on them. But we do have a new theory that's coming up. It's going to be included when I talk about these hypotheses of schizophrenia. So there has been some progress in that. But it's also inheritable. Children of schizophrenics, moms, dads have it, the closer relative connection are more at risk for having it. So there's a inheritable piece. Now, the hypotheses of schizophrenia are going to be directly related to the medication like we talked about. Early hypothesis was the dopamine hypothesis, and that was where researchers and providers noticed that there was too much dopamine, neurotransmitter dopamine, in people with schizophrenia, and directly linked to the psychotic symptoms, particularly the positive ones. So this also evolved just a bit in the sense that there was a connection made between Parkinson's disease, because that's a lack of enough dopamine. Thorazine and Haldol were noted to lower the dopamine level, and so you could see how that jump was made, because one of the main side effects of the neuroleptics was that EPS, which is characteristic of Parkinson's disease, the tremor, and uncontrollable movement, and basically movements were affected, very uncomfortable. So where we're going from here then is the next theory, which is serotonin played a role, and this was discovered because not only did researchers notice that serotonin, large doses could also lessen the psychotic symptoms, but also they had to make the comparison by looking at drugs like LSD that really affect serotonin could mimic the symptoms or cause the same psychotic symptoms that schizophrenia does. So that's how they kind of looked at that, which led to the development of Clozaril, and then also the atypical antipsychotics, which were really trying to have the same effect as Clozaril, which was a very complicated medication, but it also bad side effects of granulocytosis. So the SDAs, or second generation of antipsychotics, were looking to target the serotonin and the dopamine, but they acted as antagonists, depressing those symptoms. But also there became another side effect, and that was the heart, with the prolonged QTC intervals. So there was the risk of heart problems. So continuing to keep going, there's a third, and this is the glutamate hypothesis of schizophrenia. And this is where researchers noted that high activity of neurotransmitters, excitatory neurotransmitters like glutamate and the acetylcholines, were excessive amounts caused the frontal cortex of people with schizophrenia's brains to become smaller, and that's associated with the symptoms of schizophrenia, and medications were made to address that. Now, I'm going to be talking about Abilify Maintena, and aripiprazole is the parent drug, or the generic drug, which is Abilify. Abilify acted a little differently, so they're calling it like a third generation, and basically what it does, it acts as a partial agonist to that dopamine D2 receptor that all antipsychotic drugs target. It's just that affinity for them. But instead of acting as an antagonist, it acts as a partial agonist. So what that means is it'll work with the amount of naturally occurring neurotransmitter, let's say the dopamine, in the area of action, and it'll self-adjust. If more dopamine is needed, then it can act as an agonist, but if less is needed, then it can act as an antagonist. So it's kind of got that self-regulating role. It knows how much is there, and it somehow just knows, and we're not quite sure how it knows. But it also affects the serotonin receptor, the 5-HT1A receptor. And what that does is it also puts that serotonin in as a balance. It kind of constantly interacting with the dopamine, and the same thing as the partial agonist of this particular receptor. It allows it to achieve that balance where it's needed, depending on which part of our system it's working on, specifically the dopamine pathways. But it also addresses any mania that might come up. So, but one more thing it does that's different, and that is it does act as an antagonist to another serotonin receptor, the 5-HT2A. But here it represses it. So basically you're having a lot of tug and pull between these, the D2 receptor for the dopamine and the serotonin receptor, and they're acting like a self-regulating. They work together, they kind of push each other, especially the serotonin kind of controls the amount and pushes it and puts that pressure on the dopamine to keep it regulated where it's needed. So there's also a fourth, and that was from our professor actually, where in terms of genetics, scientists have just really discovered a gene that might be, could be another hypothesis, which is the gene that does the pruning of, with neurons, and it might be out of whack and taking too much of the neurons away. So that is really promising research. It's isolated to that 6 gene, and so, but again, it's not yet isolated fully because there's so many genes kind of that are involved in some little way there. So basically, with Abilify Maintena, the mechanism of action, and I'm taking this from an article that I found on the PubMed, which is a government website, and it's taking it and targeting all of the symptoms of schizophrenia, the positive, the negative, effectively without very little side effects. No hard side effects, and then also no EPS. So it's perfect in the sense that, almost perfect, because there are some side effects, and we'll look at those right now. What it does is our clients might experience, of course, muscle pain because it's an injection, and Abilify is very thick and it hurts when it goes in. It also can cause weight gain, so we want to look at the risk of diabetes prior to using Abilify, and we also want to look at a side effect of sleepiness, and then it also does cause a Parkinsonian-like symptom called akaphasia, which is very uncomfortable for our clients. It's restless leg, you can't control your legs. They're going to want to see their doctor. They're going to want to see a psychiatrist. It's very uncomfortable, and it's also going to frighten them for continuing the therapy, the Abilify. So this is where we can do our most work here, helping our clients understand that by the second injection, those symptoms should go away. People begin to notice and report positive effect within 2 days of taking the Abilify. Now, it doesn't really therapeutically dose as it reaches to the 4th injection, but somehow it's working. We want to make sure our clients aren't allergic to Abilify, so if they haven't been on the oral, the psychiatrist will look for at least 2 doses of oral, and then they're going to keep our clients on 2 more weeks if there's no allergies to supplement the injection and then stop that. It's also easy to get off. If our clients didn't see the doctor and stopped, it's going to be okay because it doesn't cause seizures on withdrawal. There's no addiction, and there's also a very gradual dissipation through the liver. And so basically, of course, the symptoms would come back, but no untoward side effects. There are also no risk of overdose because it does not act as the depressant of our breathing and the the automatic nervous system. So what it does is, even if our clients are still drinking, it's not going to, there's no risk of overdose. So this is really good for certain populations, because we might be working with clients who are still actively involved with their substance of choice. But this will not interact negatively with them. Now, other side effects that we really have to look for would be orthostatic hypotension. Our clients might report feeling dizzy, psychoeducation here. We also want to look at a pretty fatal disease side effect. It's called neuroleptic malignant syndrome. It's caused by other antipsychotics and other psychotropic medications as well. But here we want to look for fever, confusion, very stiff muscles, soreness, and so this would have to be seen immediately by a doctor. Then we also have some other side effects. It could affect white blood cell count, pre-existing condition, so that would be different. And then we also, not for pregnant women, it does affect the child, not for elderly whose psychosis is dementia-based, heart attack and stroke. Not for younger people, 10 to 17 is not recommended by the FDA, but I did find out in the Medicaid recs that Florida Medicaid will pay for that, the use of Abilify Maintena for children who are treatment resistant. So we just have to keep that in mind. And then there's, also we want to remember that it does interact with some medications, and this would be high blood pressure, which the doctor will monitor. And then if it's really difficult, it will reduce the Abilify. Also, any kind of benzo that is still being prescribed, benzodiazepines, monitor. If there's too much increased sedation, lower the Abilify, but really we want to lower the use of the benzo, because the Abilify should take care of that anxiety and mania because of that interaction. We also want to look at it does not interact well with Prozac or Paxil, those antidepressants, but those are also going to be being titrated off, and within 14 days, if they're not, lower the Abilify, and it also interferes with the glutamate medication. Same thing, we want to get them off of that, and then also with Tegretol, the mood stabilizers, because we want to get them off that as well. But if they aren't coming off of it, they're not titrated off within 14 days, lower the Abilify. Now, I'm going to go back to the mechanism of action because it's really interesting. And it targets Abilify targets what's needed in the 4 neural pathways. For example, we have the mesolimbic dopamine pathway. Now, this pathway is connected with the active symptoms, delusions, hallucinations of schizophrenia. So more dopamine is needed here. So it's going to act as almost as an antagonist in this pathway. But then we have the mesocortical, which is where the negative symptoms, the cognitive symptoms lie. And this is where we're going to want a little bit more dopamine to get that action up. So Abilify can be very effective for both positive and negative because it's self-regulating depending on which pathway it's working with. Now, this is going to be very confusing, and excuse me if I mispronounce, but there's 2 other dopamine pathways that Abilify helps with. The first one is the nigrostriatal, and that is where the EPS side effects are noted. So what we want to do there is partially block it. So Abilify acts as a partial antagonist and a partial agonist, depending on what's going on with the natural neurotransmitter in that area. And then there's the tuberofundibular dopamine channel pathway, and this is where there's excessive prolactin responsible for the sexual side effects, which are very uncomfortable for young people and older people, and so this limits that. So basically, our clients can have a good life. They have intimate relationships, maybe form the things that will make them happy, because people with schizophrenia live shorter lives, but also it's a young outset, so we really don't want to have their whole life affected by this. Okay, so then also I just wanted to say that we've covered almost everything except for the blood testing. There's no monitoring of the blood that has to be done regularly. Twice a year is good enough unless there's a pre-existing condition. So this makes it much easier for our clients to go to. That's another appointment they don't have to worry about taking. It's not dangerous for them. It's not painful for them. So a very effective antipsychotic, one that will keep them on a very comfortable level, and one well tolerated, even if they're still using substances, and one that is very effective for us. Thank you.